Hi, everybody. Nice to see everyone on this early Friday morning. I'm Maile Karris. I'm an associate professor here at UC San Diego. I was fortunate enough to be able to go to CROI this year and volunteered to give the first CROI talk of this year's season. And one of the things that's really a focus for the work that I do, both clinically and in research, is in addressing the issues that are uh, aging patients with HIV are starting to kind of experience. So my career talk usually tries to focus on, posters and other things around aging with HIV. And I think I curated a bunch of really cool studies for folks. So hopefully you'll enjoy. For those of you who know me, I like to be interrupted and have discussions. Sometimes that means we don't get through everything, but that's okay. So please feel free. I can't see the chat, so either Jill or Marvin, you guys are gonna have to interrupt me as needed. Okay?
I got it. Sorry about that.
That's
I'm with you.
no problem. It's casual. This is just, it's just us here, right? So again, good morning. Thanks for joining. We're kicking off our CROI series with updates focused on HIV and aging. So the agenda for today, we'll talk a little bit about the epidemiology of HIV and aging. I'm going to dive a bit into HIV and aging pathogenesis. We'll talk about some geriatric syndromes in HIV, briefly discuss some comorbidities associated with aging with HIV, and then lastly, I hope to have you all come away with some approaches to improving the aging experience in older adults with HIV. So the first poster that I'm going to talk about, the Johns Hopkins Epidemiologic and Economic Model uses HIV surveillance data like new diagnoses, median age, and current prevalence to forecast changes in populations over time. And looking at this box plot here, you can see that overall the populations of persons with HIV is steadily aging, but that there's actually some wide variability between states, with some states like Texas and Oklahoma and Arkansas actually demonstrating lower median ages over time, while people with HIV in California, New York, Florida, Maryland, and Virginia are pretty steadily aging. Overall, 24 states will demonstrate a rising median age from 51 years to 62 years in 2040, with over half of the population of people with HIV being 65 years and older. So, I think historically we've seen and heard about, oh, like the population of people with HIV is steadily aging in the US, and by, by year, blah, 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 whatever, like this percentage of people with HIV are going to be are going to be aging with HIV, 65 years and older. But I think I liked this poster because it really shows that there's a lot of differences between the states. I can kind of guess why that would be the case. But I think I liked this poster because it really did help put into context, what we all need to be working and focusing on in the states that we're in. And as you see in that plot or that chart on the lateral side of the original box plot, California is going to have a huge change in the proportion of people that are 65 years and older by 2040. So currently it's about 28% are 65 years and older, and in 2040 it's going to be 64%. So that's going to be a lot. And personally, like as a product of this HIV success, people with HIV are continuing to age in some states. But we should really, really be preparing for and considering new models of care and policy to address aging needs. So this is something I think that, we know this is going to happen. We on the ground in the clinic know what our patients are going through and what they need and where their shortfalls are. And I think it's important for us to really start thinking about how can we come together and start to affect some policy so that our patients can continue to age well. Okay. So not only are people with HIV aging, some may be aging faster than persons without HIV. The 2000 HIV cohort, which is what this is based off of, is a prospective Dutch longitudinal cohort, and it uses multi-omics to better understand immune dysregulation, comorbidities, and the latent reservoir. Um, ideally, they're doing this to try to improve personalized care. So I think there's a lot of effort now to really move towards personalized care. They evaluated cellular senescence using the gene set variation analysis across multiple ages of people with and without HIV. And at least to me, I found it really interesting that they provided evidence of accelerated aging at all ages, as demonstrated by this radio plot. So basically, you can see that populations were separated by age. So there's the young, 18 to 39, the middle, 40 to 59. That's where I'm currently living at. And then there's the older, I'm not going to say old, older, which is like 60 to 80 years. And regardless of what age, people with HIV were at, they still demonstrated more immune aging or aging acceleration, including in younger folks. So blue, that little blue kind of plot is people without HIV, and the red is people living with HIV. So we are already seeing this immune aging, even in people who are very, very young. Um, they also, and the other thing that I kind of surprised me is as I was looking at these three charts, despite the fact that they're different age, they kind of look really similar. They don't really look all that different from each other. And that also is a little bit worrisome. So they found that, like cellular senescence specifically was statistically associated with multiple medical conditions, including blood pressure, kidney function, and liver elasticity. So, like I think we're all of us as clinicians are aware that we do see a pretty high burden of things like hypertension, cardiovascular disease, kidney disease, and liver disease. And I think what this really highlighted for me is that all of this excess inflammation and immunosenescence that our patients are experiencing are really the source of all of this additional comorbidity. So because, like these changes are observed at younger age, the investigators propose that moving markers of immunosenescence from the lab into the clinic. And if we can identify people who are experiencing all of this excess immune aging, regardless of the age, that might actually help us better identify who we could target for specific interventions around this. Oh, yeah, sorry. Okay, so the next poster is from the Funk Frail cohort in Spain, and that's function frailty. And this is a prospective multi-center cohort study of long-term survivors that focused on comorbidities and geriatric syndromes. So demographically, some interesting aspects of this cohort is that they have a really high proportion of persons who acquired HIV via injection drug use. That's different than a lot of the cohorts that we have in the US. As you can see here, let's see, it was about 41% of the participants. So this is a somewhat unique cohort. Um, Looking at several markers of inflammation, these markers were significantly associated with both demographics and clinical conditions. And using a receiver operating characteristics curve enabled us to kind of get a little bit better discrimination of what inflammatory markers were associated with different clinical conditions and functional outcomes. Um, you know, the I also want to kind of present this. So I found it really interesting that they were able to identify specific inflammatory markers. So things like IL-6 and CpG methylation seem to be reflecting physical function and walking speed. So that seems to be fairly specific to that type of functional issues. Soluble CD14, on the other hand, was more associated with things like frailty and nutritional risk. So again, I think the investigators of this study are also proposing to be integrating some of these biomarkers that historically have kind of lived in the research space into the clinical space to help us better understand who do we need to be targeting for functional assessments and evaluating specifically so that they don't continue to experience more morbidity and we can catch things early and have interventions early to address and potentially diminish and slow down the eventual track to functional difficulties or frailty. So some investigators in Australia examined the relationship between cellular senescence and frailty in men with HIV. So this is fortunately, unfortunately, only a study in men. They specifically wanted to evaluate the senescence of different immune cells. And in this smallerish cohort, I think they only had 83 persons. The only clinical characteristic that was associated with frailty here was older age. So they looked at a whole bunch of different factors. And using flow cytometry, they looked at multiple markers of senescence across a whole bunch of different blood cells. And using flow cytometry, like they looked at cell cycle arrest, functional phenotype, P16, senescence associated beta galactosidase activity. And they really found they only found significant differences in men who are frail versus not frail. Similar to previous studies, senescent cell markers were associated with frailty. So, we kind of knew that already. But I think the reason why I thought this was an interesting poster is they began to think about, okay, we know this. We've seen this in a couple of other studies we've seen this in some of the studies that I've already showed you in the previous slides. Um, could we now start thinking about eliminating senescent cells as a future therapy? I mean, this is happening. We know it's happening to our population. But what can we do about it? So, the answer to that question, can we eliminate senescent cells? What can we do about senescent cells? The answer is maybe. Dasatinib, which is a tyrosine kinase inhibitor, I think many people might be familiar with related to cancer treatment, and quercetin, which is an antioxidant, um, also sometimes marketed as DQ, are drugs that in vitro demonstrate the ability to specifically kill senescent or kind of like worn out cells. There are a few small open label studies that demonstrated some decreased senescence markers. Some studies showed maybe, with the senescence markers, there were also some improved cognition. Here, investigators looked at persons with advanced chronic and primary HIV before and after antiretroviral therapy. So it's advanced, its ADV is advanced, and then ADV ART is after treatment. So they're kind of bundled together. I know this is a busy slide, I apologize. And then it's chronic, and then primary HIV infection, and no HIV, so HIV seronegative. Um, they looked at this population of people and identified just like multiple parameters that encompass senescence, like immune checkpoints and whatnot. Um, After they did this, they then took blood samples from everybody and added dasatinib and quercetin to plates, to basically blood cell plates. Um, and there's a lot going on here, so I'm not expecting people to be like, how do I interpret this? I think my major takeaway was that there's a lot of differences in cellular senescence based on HIV status and HIV stage. There's some things in here too that doesn't even really make sense to me. Like, for example, it's interesting that some of these senescent cells would go up after antiretroviral therapy in people with primary HIV infection. I'm not really sure why we see that signal, but it's there and it's different than the other cohorts of people with HIV, the advanced and chronic. So that I thought was something interesting. I don't know what to make of it, but like overall. Um, all of those with advanced HIV demonstrated greater senescence in the previous one, and the number of people in these groups were small again. So I don't know what to make of that. But after they introduced the D and the Q to the cells, there was significant decreases in the advanced and the chronic HIV populations, but they did not see significant decreases in senescent cells in people with primary infection. And that kind of makes sense. Maybe they just are too early to have whole populations of senescent cells. Um, so this ex vivo study, again, in a plate, not in a person, maybe provides some support for this DQ approach and trying to address some of the senescence and accelerated immune aging that we see in a lot of our patients, especially those that have been living with HIV for a very long period of time. Um, and we actually may have that answer sooner than later. So the ACTG is currently evaluating a DQ study. We do not have any more spots open. Otherwise, I would have put a QR code here for people to engage. But stay tuned. So this is a small study, but it really might give us an idea of, is this a strategy that we can do to help people eliminate their senescent cells and possibly improve their immune function, decrease their inflammation, and maybe those will ultimately have additional benefits on functional outcomes. So what about the impact of antiretroviral therapy? Which one is best for older adults? The possibility trial compared BF-TAF to dolutegravir 3-TC and incorporated a senescence arm. So this actually is a study that was kind of like a head-to-head study, but they very interestingly, and I think wisely, also said, hey, let's also look at senescence between the, like people who are on these two different regimens. So this is kind of like some of the data from the senescence arm. That senescence arm evaluated telomere length over a period of about 96 weeks. And telomere length attrition is another surrogate biomarker of immunosenescence and aging. So HIV itself also has demonstrated that, like there is shortening of telomeres in that context. This is partially reverse the telomere attrition when people start antiretroviral therapy, but it doesn't go back to where it was fully before. And there's also evidence that tenofovir may inhibit some telomerase activity that could contribute to accelerated cellular aging. So really the question here that they were looking at is, does tenofovir actually negatively affect older adults compared to a non-tenofovir regimen? And this is tenofovir alafenamide. So 240 persons participated in the study, and unlike our previous study, they did not have to be of older age. So this was kind of like an all takers. And if you look at the median age between the two groups, it was pretty similar. So about 49, almost 50-ish age, so very middle-aged. Didn't have a lot of female sex, but 24% is actually a pretty good recruitment number. It's sad to say that. But that's a nice goal that they were able to do. Most of the population were of white ethnicity, so there may be ongoing questions about people who were not white and whether or not this would be similar for them. And the study really observed a correlation with decreased CD4 and CD8 telomere length on both sides that were related to age. At baseline, there weren't any differences in CD4 and CD8 T cell telomere length between the two arms, but over time, both arms demonstrated decreases in both CD4 and CD8 T cell telomere length. So even, like on effective antiretroviral therapy, telomere length continued to decrease over time. Unfortunately, I didn't get to chat with the presenter of this poster. I missed them. But the poster stated that after they adjusted for potential confounders, which they didn't list, so I'm not sure what they were either, that participants on the BF-TAF arm had significantly more telomere shortening in CD8 T cells only compared to dolutegravir 3-TC. So again, that was placed in the poster, and I unfortunately did not get to catch that person when they were at their poster. So maybe there are some differences based on specific drug toxicities, but I'm probably going to wait for this paper before I change my practice. So what about cannabis? The cannabis use is more prevalent in people with HIV. Cannabis has been demonstrated to alter DNA methylation associated with epigenetic age acceleration, but the data is clock dependent. So depending on which epigenetic clock you pick, that can be very variable as far as whether or not it's identifying that there's going to be some age acceleration. On the other hand, it's fairly well established that HIV is associated with epigenetic age acceleration. I think we've seen that on study after study after study. This study evaluated 4 groups of people, so HIV plus cannabis, no HIV and cannabis. HIV, no cannabis, and then no HIV, no cannabis. So really wanted to better understand, does cannabis magnify or potentially protect this epigenetic aging that we know occurs with people with HIV? So they looked at three epigenetic clocks. So phenoage estimates biological age, and it's often tied to like a mortality morbidity risk. Grim age is actually a better predictor of time to death related risk, and I always remember that because of the Grim Reaper. So that I think is pretty aptly named. And then Dungeon Pace measures the rate of aging or speed of biological aging. And then telomere length is just a marker of cellular aging at large. So these are some of the unadjusted plots. And if you look at this from like a bird's eye view, people with HIV demonstrate overall an accelerated aging profile. It looks like that's the case. They're coming above the line of zero. Um, like I think we also see something similar where telomere length is actually also decreasing. So these seem to be somewhat consistent with each other. Um, but looking at some of the adjusted analysis, what's interesting is that in HIV seronegative persons, cannabis did slightly accelerate aging. Not unexpectedly, I think both populations of people with HIV, regardless of cannabis, demonstrated accelerated aging, but the clocks differed in whether or not cannabis use mitigated that. Um, my as of yet untested hypothesis of why there's so much discrepancy between the clocks is that maybe cannabis itself has like a positive impact on an unmeasured condition. So why are people using cannabis? They're using it for pain, they're using it for anxiety, they're using it for sleep. And if cannabis can improve those things, then maybe, there's less overall stress and aging and telomerase activity. I don't know. That's just my hypothesis because it didn't really quite make sense to me. But I guess the other side of that could be cannabis might actually be protective in some way that we, as of yet, do not quite understand. Um, if anybody has comments about this from their own research or knowledge, please chip in because I'd love to hear what people are thinking as well as we're talking about these studies. Okay. So what other factors are contributing to HIV or to aging and geriatric syndromes? This study aimed to explore the relationship between food insecurity amongst people with HIV and other outcomes. And about a quarter of people with HIV are food insecure, and that's almost double the prevalence when compared to HIV seronegative. So historically, we kind of know that. It's one of the reasons that we have a lot of policy around food services. Um, Food insecurity is associated with a lack of viral suppression, lower antiretroviral therapy adherence, and CD4 T cell counts. The authors looked at two different cohorts, so CNIX, which is a clinical cohort, and the Miami Adult Studies on HIV, which is a community cohort, and they utilized the USDA Food Security Survey to capture food insecurity. Frailty was measured using the Freed frailty phenotype. And looking at these two cohorts, there's actually quite a high percentage of men in CNIX, but a lot more variability in the MASH cohort. CNIX participants were more likely to be white. Both food insecurity and frailty were fairly common in both cohorts, unfortunately. And low food security, like limited, low food security is basically you still are able to get enough calories, but it's the quality of the food is limited and not varied. So it's like folks that are maybe buying junk food a lot of the time because that's either what they want to eat or they can't afford to eat it. Very low food security is you're not eating enough to actually meet calories. So these are two very distinct metrics of health and nutrition. There is a lot of low food security in both of the populations. It was interesting to me that CNIX was actually a lot higher than the MASH study, but it's also really worrisome that there's very low food security as well. Lots of frailty as well in this population. So 44% in CNIX were pre-frail, 11% were frail. 63% were pre-frail and 15% were frail. And when they evaluated, this cohort in general, they did identify that low and very low food insecurity was associated with frailty, which makes sense, right? If you can't get enough calories, if you can't get enough healthy foods that you need, your body may start to break down, or maybe you don't even have enough energy to exercise and do the things that you want to do. So this is something I think that I really wanted to highlight because uh, we are in a time right now when a lot of the services that I think we and a lot of our patients have depended on may start to go away, but we need to understand how important things like nutrition are in order for people to stay healthy. So I'm hoping that, everything stays the same or maybe increases funding for our patients. But if it doesn't, I think we need to really get together as a community and think about how can we help our folks be able to maintain the nutrition that they need to stay healthy and be healthy.
Miley, I'm
Yes.
really sorry I stepped out for 1 second. Ron had a question about the Peterson study. So I don't know if you can just go back,
Yeah.
where he said, the Peterson study showed worse epigenetic aging in cannabis, not protective. Is that correct?
Uh, so it actually showed protective effect in some of them.
The pheno age is higher rather
Oh,
than
I'm
lower.
sorry. But that's what the oh yeah, you're right. You're right. Sorry, Ron, you're right. Correct. I apologize. It was worse function.
Mm. So is there something more either of you would like to say about that? Is that
I think it might
surprising, concerning?
I think it might be the comorbidities that Maile was talking about that are driving this rather than the cannabis itself.
I'm
And do
glad
we
I'm
think that
glad we
group, oh,
agree, Ron.
do we know if that group's going to try to tease that out? Because that
We
obviously,
can ask Bo. They might
okay.
actually have more data here, and this is just what they had for CROI. Like I suspect that they're probably collecting more data. Yeah.
Okay,
Ron, do you
sorry.
guys have experience in your cannabis studies of something similar?
We haven't looked
Hmm.
at these markers of aging. We've seen a little bit of protection against cognitive problems, uh, but only in people with HIV, not in people without HIV.
Do
So,
you think that that's a direct effect, or do you think that that also is like it's modifying depression or, other things that can
mm,
contribute, helping
mm,
people get more socialized?
I don't know. There was a recent study, not in HIV, that showed that cannabis is not very effective for managing depression. So, not sure about that.
Okay. I saw that too. That didn't really
But
have
but
that
yeah,
effect.
the tobacco question also comes up. People who do cannabis also often smoke cigarettes. I don't know if Kalen looked at that issue.
Yeah, I mean, I suspect that there's probably going to be more coming out of this, but it's a small number of participants, like so maybe not. I'm not sure what the funding mechanism was exactly for it. So I don't know if they're going to do more or this was just it.
And Shannon just sort of wrote the same thing, lung injury, inflammation from inhalation route. But Ron, I want to challenge you on that. I don't know if there's data that shows that people who smoke cannabis are are also cigarette smokers. There are some people who use they combine their nicotine for cannabis purposes, but I don't know if there's data that shows that people who smoke marijuana are more often cigarette smokers. Is
There
that data
is
you're
in the
aware of?
general population. I don't know about HIV, but someone else
In
in
the
the
general
audience,
population, you're saying
yeah,
you have that is data you're aware of?
I'm aware of, yeah.
Okay. Okay. Thanks.
Okay. Thanks, Joe, for interrupting me. I'll pause for a second too, so
It was
for
my fault. I
questions.
stepped out for 30 seconds and I was like, oh no.
Okay, I think this is where we're at now. Yeah. So people with HIV, as we kind of talked a little bit, mentioned a little bit in the beginning, are also at increased risk for renal disease, including end-stage renal disease, but they're still less likely to be listed for kidney transplants. So factors like poverty can impact engagement, can impact access to programs, and or the ability to comply or adhere to what the transplant team wants you to do. So, take your meds all the time, get to all your appointments, eat healthy, and things of that sort. So this study utilized the US's renal data system that captures ESRD patients and linked it to Medicare claims data that identified people who are starting dialysis, as well as some country level multidimensional deprivation index, or the MDI. MDI measures health, education, and living standards, like, do you have access to clean water? Like, do you have access to sanitation and things of that sort? So really, it's an overall marker of disparities of health. People with HIV were significantly younger and were more likely to be Black and male who were experiencing end-stage renal disease. Following adjustments for demographics and some comorbid conditions, people with HIV had 20% lower odds of receiving pre-end-stage renal disease nephrology care. So they weren't getting into those clinics. They were just slowly developing end-stage renal disease. After accounting for some of the interaction between HIV and the deprivation index, the authors demonstrated that persons with HIV who lived in an area of low poverty really didn't have any significant difference in the odds of nephrology care. But if you were someone with HIV living in areas of high poverty, the odds of early end-stage renal disease care was significantly lower. So, you know, I, I'm not surprised, right, that county level poverty is negatively affecting specialty engagement. But one of the things I did want to remind everybody here is that UCSD is part of the HOPE program, which means that we are doing HIV to HIV transplants. And although the kidney is one of the most difficult organs to get, and people tend to wait and wait and wait for it, because we are part of the HOPE program, we may be able to accelerate access to kidneys for people that are really struggling with dialysis and having other issues. So when you are reviewing advanced care planning with patients, please remind them that they are able and eligible to donate their organs. Historically that was not the case, but now they can because of these HIV to HIV transplants. And if we can improve implementation of HIV to HIV organ donation, that really may be one way that we could close this gap that we see in, the persons experiencing poverty.
Maile,
Yes.
we made a very important point that I think is related to this, as well as a lot of things that we see in our aging population. My patients have had trouble getting listed because they don't have someone to support them, and professional support didn't count. How do we fix this?
I'm hoping to write a grant to fix that in the future, but
What are you
maybe.
what are you thinking about, like peer?
I haven't written it yet or gotten it, so I'm kind of nervous about. Okay,
Okay, then don't spill the beans. No, we don't want any grabbers. But I think
I
it's just
think
an important point,
I
right? For a
think I
lot of
mean
these,
yes, yeah. I
a
think
lot
that
of the things that we ask patients, you can do it as long, like if you
right,
have support,
yeah.
it is harder in people who are aging with HIV.
Yeah,
So,
so I think that's an issue, and I think the intermittent substance use is the other major barrier in our older adults because they are unfortunately sometimes still using drugs. Methamphetamine seems to be a difficult one to quit for, at least in my clinic, for a lot of my older adults because they're not using it for like chemsex anymore. They're using it to get out of bed. And just like clean their house and things like that because it gives them enough get up and go to be able to do that. So anyway, that's another grant that I've been thinking about. And we actually, so Ben Han has a current grant. I'm sorry I didn't put it in here because I didn't think about doing that earlier. But he has a current grant that's looking at why do older adults with HIV use methamphetamine. So if you have someone who is actively using, please reach out to me and I can help you get your patient, connected to Ben. This is something I think that we all see, but we don't really know what to do about besides just like continuing to counsel. And I think having a better understanding of why, like people are still using methamphetamine will be helpful for us to understand what strategies we can employ with our patients that are still, like hanging on to that methamphetamine. So anyway, sorry,
What's
sideline.
the age on that?
I think it's 50 and above. We used HIV criteria.
Thank
So anyway, um, any other questions in there or comments? Okay. So I think most of us are aware that IDSA HIV primary care guidelines is recommending at least a baseline DEXA scan for postmenopausal women and men who are over 50 years old. But evidence for this is really limited. A lot of this is driven by expert opinion. And we don't know how frequently and when to order the next one. So we know we should do it at least once, but we don't know when we should repeat it. Because there's again not really any evidence around this. This cohort study was actually done in the UK. And they evaluated the impact of tenofovir exposure and bisphosphonate treatment to kind of see, okay, like who benefits, who doesn't benefit, is there a benefit in all this that we're doing? Similar to the US, the cohort was predominantly male, with almost about 70% of them being on TDF. I found it interesting that the median age was 56, so it's a younger population that they're looking at this. And osteoporosis was actually pretty common. It was most commonly found in the spine, so about 80% of osteoporosis they found in the spine. But there was also a percentage that was only in the femur, so 7%. And at both sites, 13%. I interpreted this as continuing to support my practice of doing both spine and hip DEXA scans instead of just picking one, because, this clearly demonstrates that you can have osteoporosis in either site or both sites. So, I think that was actually helpful to see just that data alone. So they evaluated this cohort over a year and they kind of stratified them based on their tenofovir disoproxil exposure. Spine bone density statistically improved over time for almost every single variable. So including people that continued to take tenofovir disoproxil and were not on a bisphosphonate, which is also really interesting. And I don't really know what to make of this. Femur osteoporosis, however, was a little bit different. So the femur seemed to not quite have as much of a benefit to over time than the spine did, but femur bone density was less or low bone density in the femur was less common. So the authors think that the reason why there's discrepancies between the spine and the femur is just that femur bone density, the prevalence is just much lower. So, they still believe that they'd probably see something pretty similar in the femur if they had a more osteopenia and osteoporosis. So I don't really know what to take away from this specifically. I have to admit I do a lot of DEXA scans, and that's because I've had older adults fracture, and it kind of makes me very worried that I am missing opportunities to prevent a fracture when they fall or, like when something happens to them. Um, but I do think we probably should be doing more DEXAs in men. So I tend to do a lot more DEXAs in women. But I think that this data really convinced me, maybe even at earlier ages, to start doing DEXAs sooner than later. I don't know what to do about bisphosphonates. I think I'm still going to treat when I find osteopenia that meets the current criteria for treatment. But I don't know, how frequently to be repeating. Um, I do think though is that, what they didn't include in the study is whether or not any of these participants were also, on other interventions to build bone, like vitamin D, if they were doing weight-bearing exercises. Um, So I don't know if maybe there's something in the background that is being routinely recommended in the UK that maybe we're not doing as much that would be different if we did this in the US. So I don't really know. This is a study where I'm like, this is interesting, but I'm not sure what to take away from it, except maybe being a little bit more aggressive with earlier DEXA scans. Um, regarding DEXA scans, I'd love to hear what other people are doing in the community. Does anybody have like something they feel comfortable sharing, an approach?
Well, Maile, it looks like Niddy put in the comment section, I don't know if you can see it, at the Ryan White Clinical Conference, Roger Bedimo gave me an earful. Aside question regarding questioning the massive increase of use of DEXA, which was studied to determine osteoporosis in older women. We don't have data telling us how to translate that to all people with HIV over age 50. So resource allocation talk from last week comes to mind, and possible unintended harm of over screening.
Yeah.
I don't know if Nettie, if you want to unmute or.
Well, you summarized it so well, Dan. Yeah, I mean that I do follow the guidelines and I do a ton of DEXA scans, but I've been around long enough to have followed many an over screening guideline and been bitten by it with lots of repercussions, like doing anal paps in people who are 25 and things like that. So I am very skeptical of this. Of us doing all this scanning without knowing what we're supposed to do with it. But yeah, and Aaron's, yeah. But again, do they have osteoporosis? Like, I don't know how to interpret do we interpret a DEXA scan for a 50-year-old guy in the same way? Like, it's just unclear. So I do it and I treat people according to how we treat
Mhm.
osteoporosis or osteopenia. But I do wonder about it. I will say that it is a great opportunity to talk about weight-bearing exercise and nutrition. So I get a lot of osteopenias, and it's a great opportunity to remind people about the importance of using their muscles to strengthen their bones. So that is something.
And vitamin D. Um,
Yeah,
Yeah,
and
and
there's a comment from Aaron. I've been increasing DEXA scan, surprised at how many younger folks have osteopenia. I've contacted endo for a patient who suffered a humeral fracture with osteopenia, and they didn't advise any bone generating treatment because he was otherwise young and healthy.
Well, I mean, I think these are areas that have never been studied, right? And so I would think if you were young and healthy but had osteopenia, and if you've already done the vitamin D and you're doing the weight bearing exercises and all those other things, and you repeat it and it's still osteopenia, I don't know. I guess we also don't know like the risk of using bisphosphonates in younger populations because it's never been evaluated in that population either. Um, Sounds like maybe something that we can do in the ACDT or something like that. Because it's for people to fracture, and I've now had unfortunately several men significantly fracture themselves while they're just doing, usual day-to-day activities. It can really cause a lot of issues. And I think all of you probably have experienced that. It can knock them off their health track for a long period of time because they have to not weight bear if they're like if it's a foot. And then they lose more muscle tone. And so this is a big issue that maybe we as a community need to put a little bit more pressure about, hey, we just need more guidance here. We need more studies.
yeah, and then Gigi made the practical point, and I don't know what people have seen, but that coverage for
DEXA.
cisgender men is more challenging. I don't know. Right, they're recommended for what above for the general population above 65, is
Yeah.
that correct?
Yeah.
So are people seeing that 50 to 65 is a very, yeah, and I don't know. I thought that you could, right, Medicare would be the one that should be, I would assume Medi-Cal wouldn't be an issue, and I would think that the commercial insurers are some sort of black hole, and who knows, but yeah,
Yeah,
that's a problem.
everything is getting more difficult now too, right? Like this year has really been it's impossible to get anything done for our patients, it seems to be. So anyway, okay.
Back to you and mileage. Oh, I thought someone said something. Just so you know, it's 8:45, okay? But
Oh,
don't worry,
okay.
you're good.
I'm gonna skip this then, another bone density thing. I don't. Yeah, let's kind of skip some of this. I'm happy to I'm happy to circulate slides if people want to just take a look at this stuff too. I'm sorry, I want to kind of go on a little bit more and then have maybe a little bit more discussion. So polypharmacy, defined as 5 or more non-HIV medications, is very common in people with HIV and especially in older adults with HIV. This Swiss cohort looks pretty similar to our San Diego cohort, except we likely have a little bit more racial diversity. About half of the persons in this cohort were regularly exercising. A third were current smokers, and most were, virologically suppressed at baseline of the study. Over a period of 8 years being followed, 4 polypharmacy trajectories emerged. So we have this kind of like stable non-polypharmacy. So people are just kind of taking the meds they've been taking for 8 years and they're not getting anything more than that. And so that's one of them. We have another trajectory where it's like rapidly increasing. So people are accumulating like 5 to 8 medications over this period of time. There's a slowly increasing 1 to 2 meds over a period of 8 years. And then there's the rapid progression in short period of time. So that's like anywhere between 1 to 6 meds in a fairly rapid period of time. At the end of this study, only 46% of people with HIV remained on less than 5 non-HIV medications. So almost everybody was started on some sort of additional medication. Stable non-polypharmacy had a lower proportion of persons with obesity, a history of smoking, high alcohol consumption, or illicit drug use, and a lower prevalence of comorbidity. So they were just overall healthier. Rapid progression had the highest proportion of heavy smokers, heavy alcohol drinkers, highest prevalence of cancer or cardiovascular events, and the highest proportion of missed antiretroviral therapy. So I know it's going to be really difficult to do this, but really to enhance aging for people with HIV, we need to really focus on all of these modifiable things. Substance use, taking your meds all the time, making sure that you're getting screened for usual things, cardiovascular disease and whatnot. So, I mean, and art adherence as well. So I pulled up this geriatric 6Ms because I think if you're not doing a geriatric approach to care, one of the things I would love for you to be able to take away from this slide is like, what are the things that I can modify about my patient that has the potential for like a huge impact? So really think about the modifiable when we're looking at the patients in front of us. And if you don't want to do cognitive exams and frailty evaluations, fine. But think about what can I do? What can I take away? What will actually help this person continue to be healthier? So within the general population, there's an association between obesity and comorbidity, specifically cardiovascular disease and cancer. And in HIV, we don't actually quite have the evidence to support an association between body mass index and risks for things like heart disease. To better understand, like if this association is also present in HIV, the Swiss cohort study evaluated the long-term risk of clinical events associated with starting antiretroviral therapy with a BMI of greater than 30 or not. And I think it's probably the best plot to look at is this Kaplan-Meier estimate. So you can see that if you are starting off with a higher body mass index, you are actually going to have higher probability of poorer outcomes overall. 15 years from ART initiation, the risk of cardiovascular disease, cancer, and death was 19% in the obese and 12% in those who were non-obese. So that's a big difference. The impact of obesity on these outcomes is more prominent in persons who are younger. And that being said, that might be due to like a survivor bias, as we see here in this corner here. So it's highest in the younger, but again, maybe the older are just not experiencing the consequences because they are passing away. But really for me, it underscores the importance of counseling persons and providing interventions to address obesity at ART initiation. So I don't know how easy that will be to integrate into our, like 15 to 30-minute visits, however long everybody has. But I do think that this is something that might actually significantly benefit our patients from the beginning. Okay, almost done. So I wanted to actually talk a little bit about women because there's very few studies focused only on women. And women living with HIV are at increased risk of menopausal comorbidities like cardiovascular disease and osteopenia. Hormone replacement therapy may be a way to improve these outcomes and overall quality of life. Using data from the DC longitudinal HIV study, which incorporates demographics, socioeconomics, HIV labs, comorbidities, and others, including menopausal symptoms. Metabolic measures were evaluated between women with HIV that were on and not on hormone replacement therapy. Women with HRT use were more likely to be older. They had higher CD4 T cells and higher levels of viral suppression. They were less likely to be unemployed, and most of them were not Hispanic Black. Women on HRT were also more likely to report urogenital symptoms. They were 2 times more likely to have osteoporosis, being overweight, and also experiencing hyperlipidemia. So among HRT users, women with HIV 40 years and older was associated with increased odds of comorbidities and pre-HRT menopausal symptoms. So they're having menopausal symptoms, they're getting HIV. That was HRT. That was one of the associations seen. And they also were experiencing osteoporosis. They're getting HRT. Although HRT amongst this population, so this was a cross-sectional study, which made it really difficult to determine cause and effect. And it's really unclear if the associations with HRT are actually attributable to the HRT or if they were already there and subsequently, like HRT is also along for the ride because of the menopausal symptoms. But one thing and one reason why I wanted to also show this study. So basically we don't know if it's safe or helpful to use HRT in women. I think we are, but there is an upcoming ACTG study that is going to look at this exact question called the HOT study. This is a QR code. If you're interested in learning a little bit more about that, it's not yet open, but we should be open soon. Please reach out to us. We would love to be able to fill this. This is something I think that's a really important question that's been difficult to answer just using the cohort data that we have. So I'm kind of going to just wrap everything up with a focus on what we can do to address aging and comorbidities. So I hope by now I've convinced you all that people with HIV are experiencing greater and earlier comorbidities. The HIV seronegative than HIV seronegative persons. This is a secondary analysis of the ALERT and HALO studies, which were both longitudinal studies of older adults with HIV. They evaluated 2,940 unique participants over a 24-year span, although the average follow-up time was only 6 years. But they were looking at this question over a couple of decades. And in that period of time, 260 serious non-AIDS events, including 126 deaths, 134 non-fatal cardiovascular disease events occurred. And self-reported ART throughout the study was very, very high, about 97%. But ART adherence was actually the primary thing that was significantly associated with whether or not someone experienced their first serious non-AIDS event. And it also is correlated with any and all serious non-AIDS events over the duration of the follow-up. So basically, this study is saying, take your HIV medications all the time because it decreases inflammation and it might prevent or probably will prevent future heart attacks and strokes and other comorbidities that are associated with excess inflammation. I know that it's not popular, especially with our medications are so good now that you can miss here and there and not even have a blip or anything of that sort. But there is a cost to not taking it every day on inflammation. And Jose Castillo Mencia is on this abstract. He actually did several, actually maybe closer to like a decade ago or so. He looked at inflammation, multiple inflammatory markers based on how adherent people were. And even back then, it demonstrated that 100% adherence is different than 90% adherence as it relates to inflammation. So I don't know how we can improve this. I know that a lot of the pill fatigue is real and I get that. But if we want to truly minimize the risk to the people we take care of, this is a message I think we need to be communicating more effectively. I do wonder, and I think that it will be really interesting when we have enough follow-up time. Do we see the same thing with long-acting injectables? Does long-acting injectables, because, like you have just consistent period of time when you're covered, are we going to see lower levels of inflammation and subsequently less of these serious non-AIDS events? Really looking forward to hearing if that pans out.
Maile, Katie asked how adherence was measured.
They're the ACTG adherence measures are self-report. Yeah. Even with self-report, right? There was still a signal. Okay, so again, this is another study. Again, I just keep thinking about like what can we do, like to help our patients continue to age well, and it's always the same stuff. So to better understand really like how diet and physical activity associate with symptom burden, this study evaluated 704 virally suppressed adults that were engaged in HIV care and had them complete these objective assessments of physical activity. They were wearing an actigraphy watch, as well as document their diet intake and then their reported symptoms in the past months for 3 years. So this is actually a pretty long study. The authors then used linear mixed models to analyze the impact of physical activity and diet quality on symptoms. Participants were from very diverse ethnicities. Overall, they were pretty functional when they were assessed, but they had really, really poor eating habits. And really that means they were only meeting the current federal guidelines for diet about 47% of the way. And that's considered just like very, very poor. People with a high burden of symptoms over the past 30 days often reported things like muscle aches, insomnia, fatigue, neuropathy, were in general stable over time. So things didn't really change between, like the beginning and the end of the study and over that period of 3 years. But people that engaged in more steps, so counting the steps through the activity, and who consumed better quality diet had reductions in their symptom burdens. So addressing those two things, take a few more steps, like tell me about, like what you're eating, how can we help you eat a healthier diet, are actually very effective ways to improving the health of the people that we're taking care of. Okay, and so this is a QR code actually to one of my research studies. We are partnering with Christie's Place, and we're running an intervention that includes exercise, acceptance and commitment therapy, and empathetic social support. So if you would like to get one of your women and or trans women to do a little bit more exercise and take more steps, please feel free to refer them to our study. We are also giving away Fitbits to help people manage that as well. Okay, so overall takeaway, HIV and aging. People with HIV are continuing to steadily age. We really should be thinking about how to integrate geriatric principles into the care that we're currently providing. Cellular and epigenetic markers of aging are associated with comorbidities and geriatric syndromes, and some may be specific for different conditions. I don't know if we're going to be using these markers in the future to help us stratify persons for specific interventions, but it is something that a lot of people are bringing up, so this may be something coming. Health inequities continue to contribute to frailty and impact access to care. We need to really think about our current HIV policies and explore if they're sufficient to meet the needs of our older adults with HIV. The future of HIV care is going to be managing and preventing comorbidities, at least in California. And studies consistently demonstrate that physical activity, healthy eating, connection, and management of other modifiable components are key. And then lastly, we really have an amazing opportunity to work together to implement strategies that help the people in our care age well. And I know that we're from different clinics and we see different populations, but I love to continue to get together with you and hear what you guys are doing and maybe even partner with some future initiatives. Okay, thank you. Any other questions? Okay, I just made it.
Oh, it's 9. For some reason, I thought it was 8:55 or 8:58. You did it. I don't think we really have time right
Yeah,
now.
sorry.
And no, you did. We had no apologies, Miley. This was amazing. People were thanking you already. This was an incredible summary of what happened at CROI and future discussion. No, this was wonderful. If anyone has any questions for Miley, please email her directly. Yeah, I think this was recorded so people can watch it again. And yeah, that's it. Thank you so much, Miley. I don't know if Dan, you have anything that you want to add. We did this together.
No, but thank you.
Have a great weekend, everyone. I believe our CROI review series continues next week.
Who's next week?
Would you say who's next week?
Well, next week we're off, but then
Oh,
Never mind. We're
the
off
next
next
the
week.
next three
Let's
sessions will be CROI. I can't remember who the next one is.
Yeah, well, there'll be an email for the month of April so people can
Yes.
see it, but enjoy next week off on Farm Workers Day.
Farm workers, yes.
Yes. Leave you with that. We'll talk soon. Bye.